really an important determinant of how they will do and the outcomes that they'll have. And we all know the lack of of access to critical care services on the continent. And so really excited to have great speakers today. We've got two speakers, Dr. Dave Thomson, who I'll introduce shortly, and we've got Dr. Shrikant Peters, who will give his talk first. Dr. Peters, we all know, he's very much part of the global surgery family. He's part of our steering committee. He chairs our education committee as well, lectures on all of our courses as well. But most importantly for today's talk, he's the theatre manager at Grooteskier and also responsible for anesthetic and critical care services. So Shri, you can kick us off and then we'll move on to the second talk after that. Thanks. You muted? You muted? Are you able to unmute? Is it frozen? Mm. Anything we can do, Shri?
Hi, sorry, Salome.
Okay, cool. Now we can hear you.
Do you hear an echo?
Not really. You can keep going.
Okay, great. Can you see my slides?
No.
Okay. And now?
Not yet.
And now? Nothing's.
No. No, I can't. Yeah.
Okay, sorry.
Okay.
Just tell me when you start seeing it.
Okay. Not yet.
Okay, sorry. In and out one more time. Sorry.
Okay. Mm, no.
Still nothing.
No, not at all. Do you want to maybe email to me or Amy?
Yeah, I can. Why it's not. Okay, I'll email it to you.
Okay. Okay. And it looks like we've also lost Shri. Okay, he's coming back in.
Slowly, if it doesn't work
Yeah.
now, I'm just going to speak from, I'll just speak without slides. Is that okay?
Okay. All right. So just try one more time. Also, yeah, your video as well. And let's see. Now it's showing.
Oh, great. Fine. Okay. I'm going to
Okay.
turn my video off just in case. Okay.
Okay.
Thanks very much, Salome. I'm sorry about that. I have no idea what happened. So you can still hear me, right? Just last time?
Yes, yes,
Yeah.
we can.
Okay.
Thanks.
Thanks,
Mhm.
everyone. So I'll just be taking 15 minutes of your time. Thank you very much. My name is Shrikant Peters. I'm the medical manager for theatre and ICU at Kruitskia Hospital. And I'm going to be introducing the important work that David and his colleagues do in ICU, but just providing you some context as to how the service is managed. I think it's quite telling. The first time I met Dr. Thomson, I was a medical student and he was a registrar in general surgery. And that was at Red Cross. He was doing a laparoscopic appendectomy. And it now seems like a lifetime ago. But it definitely does mean that we both find ourselves in places which we never expected to. Myself, coming from public health into management of theatre and ICU at a tertiary service, which is the last place I would expect someone from public health to be. And Dr. Thomson in intensive care, a place for very smart people, and he came from general surgery. So just some acknowledgements in the slideshow. I'm going to be talking to you about how we manage the service and how that quality of management plays out in the quality of care that we receive in different hospitals. You might have seen articles recently bemoaning the lack of quality management at our facilities and the fact that quality care is just impossible without good quality management. And we really need to start discerning some of the lessons in functional spaces. So what is the typical journey of a manager? I like to joke that the CV of a manager just needs to include that you've got an MBCHB and a pulse. But jokes aside, there are specific skills and knowledge that are required for managers. Not everyone who is a manager would have studied something along the lines of public health or public health medicine specifically as the specialty program. But anyone who has a medical background that has worked in the Department of Health has a knowledge of structures and processes and is au fait either in content, if not then the practicalities of systems thinking, understanding how elements of the Department of Health work together to create health for individuals as well as population health for our province. So what the Department of Health looks like in the broadest terms. So what you'll see here are a range of different players who would manage the district, regional, and tertiary service. A lot of them are medical doctors. Obviously, most of them are no longer clinically practicing, but they do have that as a bare minimum of their jobs, is that they do need to have medical training and know what it's like to work in our facilities. And then the right-hand side of your screen would be people involved in strategy, finance, human resources, information management. And so I do say that we've got a functional system governing us in the Western Cape, with layer upon layer of planning. This was a plan that was drawn up during COVID. And so we clearly have a functional system because we have plans that are put in place at a provincial level that then the facilities are responsible for managing. And so at the end of the day, the general public would see data like this. So we're collecting stats on all of our COVID patients, the number of deaths, what are the kind of comorbidities, what are the real-time odds ratios of patients dying of COVID, and how do we better adapt our services accordingly. And at that level, we're tracking everything from cases of COVID to oxygen levels at facilities, number of people admitted, the number of deaths, the test positivity rate before a wave. But all of that has to translate at some point at the managerial level at each facility. And so this is what I term the shadow structure of management at Groot Schuur, because we're not heads of department, we're not responsible in line management for the clinical departments, but each of the medical managers has an allied service. So for myself, it's perioperative and critical care. Included in that is anesthesia. So as the medical managers, we are responsible for both the clinical and corporate governance of the service. The clinical governance, even though you might not interact with it much until your senior years as a consultant, we understand that it has something to do with quality of care. It's about continuous learning in a service. Morbidity and mortality reviews are these rich learning experiences of things that have gone wrong that we'd like to improve over time. But underpinning clinical governance is this want to maintain and improve our standards, and to create an environment, a working relationship amongst professionals where clinicians can contribute to a learning organization. So for me, I see myself as standing in the middle of a T, and that the silo is the clinical department of anesthesia, within which is the critical care division. And it's my responsibility to connect them to the corporate services, which is obviously at the top, the hospital board. But before we get there, we need to talk about human resources, about information management, making sure that we've got access to clean water and electricity is sometimes can be hair-raising, and you never hear that there's a problem, but it can be a struggle at times. And so we connect the clinicians to the wider system as well as to the other clinical departments. And at the end of the day, we still need to be a going concern. We need to have money in the bank, and that's primarily our concern, as well as balancing that money with what we do with it, and the money that we do spend is spent appropriately. And so at the end of the day, it's our job for the clinicians to create functional teams, and where there are gaps in that, to reach out to either nursing or allied health or other clinical disciplines, and build that vision of a service that's functional and understands each other, and gets along, and is able to generate good patient outcomes. Not all facilities are like that. And our junior years anyone who's done junior work in the departments of health will know that a very rancorous clinical environment is not conducive to good patient care. So at Groot Schuur, we work in functional business units, and they're basically the unit. So you might hear this term called a health district for a geographic service area, and there's a suite of services that should be in that health district. In the facilities, we have functional business units. And so we've got a business unit for theatre, and it's basically the non-clinical manager, myself, and the head of the clinical services. So either the head of department or his delegate, the head clinical unit of anesthesia or ICU. And we would get together, we would look at our throughput measures, our quality of care measures, our outcomes of a service, and how much money we're spending to get there. And it's this idea built in that with the non-clinical manager and the clinical manager working together with the corporate services and the rest of the clinical body, we need to actually return agency back to the clinician who understands what is good quality of care in his service, and understands the requests he needs to make of management. And management obviously needs to translate that. And so it's important to have understanding both from the world of management and finance and economics, as well as a basic understanding of the clinical department. So it's our role to set a vision for the hospital, and the vision at Groot Schuur is leading innovative healthcare. And we've got building blocks as how to get there. We very much pride ourselves on service excellence and innovation, and we work towards developing leaders. So that's a lot of management speak, but it does play itself out in the clinical disciplines. And we know that we have budding service innovators of the future. David Thomson has been working tirelessly at getting transplants off the ground nationally. To do that, we need to actually have functional pilots in the facility. So when we say pilots in management, we think of learning cells, and this is a concept from lean management. And as management of a service, especially in healthcare, we would ask ourselves, how do we increase value for a patient? How do we decrease wastage of resource? And how do we decrease delays to treatment? So I won't go through all of that, but there's we try and thread through, as you would a research proposal. We'd have to have guiding principles from management, actual systems to manage our data, and to get results at the end of the day. with avoiding the types of waste that we see in healthcare often. My favorite one being a waste of human potential, the waste of not engaging employees and listening to their ideas and supporting their careers. And we've seen in COVID, when we support our clinicians, we have magic results generated. Okay, so just basics about budget in the country. We know that we're dealing with budget shortages, but we're working on around about now 25 billion for the province. It's our responsibility to measure that finance against a service output. It bleeds its way all the way down to theatre and ICU, and we know that in theatre and ICU we use 600 million rands a year, so we do need to account for that money. In terms of our outputs, so this is a typical access graph which we'll look at on a monthly basis at our business management meetings. The yellow line sort of that's going across and has just tipped up in the last 2 months. Those are the number of patients who have been referred for ICU to whom a bed has not been available on the day of referral. So that's obviously a problem, and we need to watch it very closely and try and decrease that number as much as possible. Behind that number is obviously a length of stay. We also try as far as possible to decrease our length of stay. We don't want people intubated and lying on their backs for too long if it's not needed. And we look at our patient days, we look at length of stay. If one were to look at mortality versus admissions, this is a very easy graph to read, more than normal, simply because you can see the effect of COVID in our mortality rate over time. And so it's obviously important to know that management is aware of what the mortality rates are for different services, because at the end of the day, we need to make distribution decisions. The same goes for understanding the acuity of our cases. So we have an understanding of the proportion of patients on ventilators. But the nuts and bolts of business unit management is about the finances. And so you can clearly see in ICU, which is more of a, usually more of an average line. We've got increasing expenditure, increasing lengths of stay, increasing occupancy rates, despite expanding the bed offering at the peaks of COVID. And it's not uncommon to see this on a smaller scale at the end of a month weekend, for instance, when our trauma load increases. But it's important to know that this all has an effect on budget, and that the budget has a fixed space in which we're working. So I'm going to finish off just with the example of COVID, because it was a major learning lesson both for managers as well as clinicians as to how we could use each other to improve the volumes that we're getting through and decrease patient mortality. So this is going to be a very, very difficult graph slide to read, but it's supposed to be. But if I had to explain to you what we had to do to accommodate a surge in demand of services, this is the slide that shows it. So all of the extra space that we had in our high care units, in our allied ICUs that were not part of consolidated ICU, we had to convert into COVID ICU beds. Now that's, it's a lot harder than making a slide on a page. It meant getting extra beds, extra ventilators, extra consumables, extra food pumps, volumetric pumps, syringe drivers. All of these things for a non-clinical manager would pretty much be impossible unless you're actually engaging your clinicians on the floor. And that's what we had to do, is sit down together and find out what was the requirements for an escalation in service, write the proposals together to provincial management and take it forward, and then implement it on a project management basis. Obviously, as the manager for theatre and ICU, I need to balance both theatre demands as well as ICU. So this is another complicated graph of de-escalation and escalation of theatre and ICU respectively, and they're competing resources because they use the same staff. But it's the same discussion across the board as to how much time, how much beds, how much operating time we give to different specialties. The one difference in medical management and when you become a senior clinician is that, we know that from undergraduate medicine, we have to advocate for our patients. We understand that. But what do you do if you've got 100 clinicians lined up all advocating for their own patients? How do you manage that? And so that's where the resource distribution and equity of resources arguments come in. So as a registrar in public health, I would be confronted by two heads of clinical unit, one from ICU and one from surgery, who could not agree on giving a patient a bed. And the funny thing in that instance is that the decision is then left up to a junior non-clinical registrar to make the decision, but it's simply because you're in a non-clinical managerial, hopefully unbiased position to make those kinds of decisions. So sometimes medical managers are necessary evils. So, in ICU, we normally would run 25 beds. David will take you through the ins and outs of ICU, but the concept of a consolidated ICU is something that's being implemented more and more over time. We've done it at Kruitskia, Tygerberg are yet to, but it means that whereas in private or in Tygerberg, where it's each person to fend for themselves, whether you go to the surgical units or the medical units, they don't share beds, they don't cross-pollinate ideas. We have consolidated our service. From a corporate point of view, all of our posts are held under the Department of Anesthesia, and we use our 25 plus 2 beds for everyone's benefit. And so that can only be accomplished if you've got corporate managers who understand the value of a consolidated ICU service and the quality of care that goes with a consolidated ICU service. And so in COVID, we escalated by 42 beds, and that was stretching the system, but it also needed the buy-in of surgical divisions, and we couldn't have done that without boundary spanners like Dr. Thomson, who counseled the Division of Surgery regarding their loss of theatre time and the fact that waves would be temporary, but deaths would be permanent, obviously, if we didn't prevent as many as we could have. And so together with that, we reached out to the rest of the department. We had an intubation team from anesthesia who pulled in our patients from the wards, offered a service where they had at least 2 anaesthetists at the bedside. Now with an intubation service, it's just an example of what's required. You can have the clinicians there, but they obviously need all sorts of equipment and consumables. And I've pulled 2 tables from one of the articles that came from the intubation team. And so, you need the people there, but those people need a range of capital equipment, not all of which we had at the facility prior to COVID. Transport ventilators were a problem and transport monitors as well. So that required us to liaise with health technology. At short notice, I was sitting in an empty room, which was needing to accept patients the next day. And a call to the Provincial Department of Health meant I had 6 fully equipped beds the next morning that we were helping the Clintex put together. That was then full of 6 patients the next day. All requires money, all requires dedicated people, but it's really great to see it coming together. And that's all the consumables required, which is obviously high turnover. In management, the difficulty in managing a healthcare service is that you have this thing called clinician autonomy. So you need obviously the staff. They need to understand their roles. They need to have autonomy. They need to be able to have agency to adapt the service in the ways they see fit. And it's the manager's role to make that happen. And it's a headache. So, we were sort of overloaded with changing rosters all the time. And this was one of the rosters that Dr. Thomson had to work out on a monthly basis, pulling in people from all sorts of different divisions. We also had a high flow service going. We know that we had we had huge numbers of ICU admissions, and to absorb that, we did escalate our beds as well. We also have an understanding of our outcomes, and it's because we have an academic center that we're able to do that. And we should be proud of our response, and we are proud of our response and of our clinicians. But management is never an easy space. Even though COVID's over, we're now trying to get back to our normal lists. We've got significant shortfalls across the country, and we're dealing with an increasing burden of disease. Those problems are not going away in the way that COVID had done. So the way forward for management and our clinicians, we still have to hold tight. I've done this for COVID many times, but we're escalating theatres now. We still have to train or reskill our registrars after a period of being unskilled. We need to still understand what's our maximum capacity across the service. And we still need to make sure that our staff are personally and physically safe, and that their well-being is looked after, and that we're communicating well, both with our clinicians and with the managerial staff. Thanks very much. Whether you're in clinical work or in management, you'll still feel post-call at the end of the day. Thank you.
Thank you so much, Shri. I mean, always fascinating to listen to the other side, the management side of things, and looking at the health service from a public health perspective and management side. I don't know if we've got any questions, but maybe we've got time for one question, and then we can move on. Okay, if there's no questions, you can also write in the comments. But thank you so much, Shri, and thank you for making the time and for sharing this perspective. I'm going to introduce Dave. We've got Dr. Dave Thomson. He's a consultant surgeon in the transplant unit and a subspecialist in the critical care department at GSH and UCT. He completed his undergrad training at UKZN in 2002, went on to specialize at the University of Cape Town, got his FCS in 2011 and MMed in 2012. He was awarded the Garen Kane Traveling Fellowship by the Harvard Center for Surgery and Public Health at Massachusetts General Hospital and Brigham's Women's Hospital in Boston in 2014. He completed his subspecialist qualification in critical care in 2015. Currently works in the ICU, directing the ECMO program at GSH. Actively involved in kidney and liver transplantation, has a special interest in medical education and promoting organ donation and transplantation. So thank you very much, Dave, for joining us, and looking forward to hearing your talk.
Cool. Thanks very much, Prof. You can hear me okay?
Yes, perfect.
Cool. Just to say, Shrikant implied I was responsible for a lot of the response to COVID. I was allocated rosters and tasked with upscaling. I think the COVID pandemic has definitely altered our relationship with management. I hope to the positive in terms of healthcare services being treated more dynamically in terms of being responsive. And I think we realized the importance of measuring things. And I think that might come through in this talk as well. So just in terms of critical care services in Africa, I've got no financial disclosures or conflicts of interest. So I am an intensivist and a transplant surgeon, and I'm based in Cape Town, UCT. The country I'm in is an upper middle income country, and if you start to talk Africa, how do you divide it? Well, I would classify the sub-Saharan Africa in 54 countries and 1.1 billion people, and this isn't often appreciated by the rest of the world. And if you look at the healthcare provisions, Uganda gets about 1 ICU bed per million population. South Africa gets around 8.9 ICU beds per million population, but there's a catch to those numbers. And we know South Africa is not the most equal country in the world. It's the most unequal country. So the people on the right seem to access a different level of healthcare compared to the people on the left. And if you look, this is now 20 years out of date almost, but in the South African sector, 30% of the doctors care for 84% of the population, 70% of the doctors for 16% of the population. And the per capita expenditure is 10 times higher in the private sector than in the state sector, with 25% of our population paying out of pocket for some healthcare support. So when we're classified and Grooteskier gets labeled as an upper middle income country, I'm not always sure that that's completely true for our particular circumstance. But if you do compare us to the rest of the country, our life expectancy is 10 years more than some of the other provinces in South Africa. But we are a government-funded hospital. So there's lots of challenges in ICU. And the first one I'll put to you is measuring outcomes, because it's very easy to get good outcomes by using ICU for very healthy patients. And that's a tricky one to actually balance. And then the other part is not all ICUs are created equal. And if you think within ICUs in terms of the monitoring, the provision, the levels of support, the levels of training of people, the capabilities, it's not so easy to just decide what is an ICU. And this came up when we tried to put through a welcome grant, because how does welcome actually define critical care? Do you define it by the severity of the patient's illness? Because we definitely have critical care needing patients. They're just not always in ICU. They're very often in the emergency department in the front room. Or is it actually the location in which critically ill patients receive care? Is that how you define it? And then you classify the space and start measuring it from within that space. And that is actually still up for debate. So how you define critical care when you start to measure it and report it is quite important. Then when you get to defining a critical care bed, do you use it on a nurse to patient ratio? Do you use it if you've got critical care specialist oversight? There are not very many critically care trained subspecialists in South Africa. Now, Shri already broached the COVID-19 issue, and I'm not sure what everyone's feelings are in the audience, but it was tough, but it really did shine a spotlight on health and at least move us forward a little bit in terms of public engagement on those things. And Shri's already shown some slides from our sort of organizational response on the critical care side. But it was a very massive expansion, and that's on top of a 25-bed ICU that's already declining, around 5 to 15 patients as good candidates, assessed as benefiting from ICU care, and we say we unfortunately no capacity to accommodate you. It is a dynamic moving goalpost, and that's the unfortunate burden that gets transferred onto the critical care specialist to be making these type of decisions. We have a service that's got 2 ECMO machines, 3 continuous dialysis machines, 6 intermittent dialysis machines, and at the start we had 4 high-flow nasal oxygen machines. That's greatly expanded since COVID. And we're staffed by some part-time staff and some full-time staff, but basically the 5 intensivists are supervising doctors who are rotating for a 3-month cameo in ICU. So it's a lot of supervision and training that has to go on. And if you looked at our oxygen consumption as a hospital, we used 1 ton of oxygen per day with 30 tons of storage on site. And then in COVID, critical care services upskilled, upscaled, hopefully upskilled as well. And we commissioned those extra spaces. And ward spaces were commissioned to deliver high flow nasal oxygen that quite often around the world was actually given in an ICU setting. We didn't get extra hospital staff or repurposed staff from other departments, and our oxygen consumption went to 15 tons per day, and we added some extra storage because that got very tight at some points in the pandemic. We published our outcomes, and I think it is really important, as Shri mentioned, to be able to publish your outcomes and to be critically reflecting on your service, because otherwise it's all speculation. And part of the challenge in COVID is there's a lot of speculation, and people speculate outside their areas of expertise because it suits their narratives. So I think it's really important that you do continue with peer-reviewed research and publish it and continually critically reflect. So over the 3 waves, we put through 743 patients on ventilators. And because we actually upscaled in high flow nasal oxygen, and if you want to include those in our ICU capacity, then that's doubling the numbers of this hospital's workload related to COVID twice again. So we used high flow, and if you look at the paper by Greg Caligaro, you would see that the severity of illness would qualify people based on this is your inspired oxygen to the oxygen ratio coming up on your SATS probe. And that 68 is indication for ECMO pretty much universally. And those patients were getting high flow in our setting. And it's interesting in terms of the naming of the setting, because you'd look at the literature and you'd find effective timing on intubation of intubation on clinical outcomes. You know, was having an intubation team an appropriate response? Did we need that? Well, the literature doesn't really answer that question, because in this study, they used 2 definitions of early intubation. One was before or within 24 hours of ICU admission, and one was before a trial of non-invasive mechanical support. And they redid their analysis with these 2 different definitions. And we had to write a response because just by changing the definition, our entire cohort of patients managed at Groote Hospital would change from the one arm to the other arm. There are huge challenges in ICU measuring the data. It is a lot of data to try and interpret in order to work this out. The triage criteria have already come up in terms of how we were trying to offer our services fairly and equitably. And it was very tough because it became saturated at the top in terms of what we thought was a discriminatory system, in terms of being able to effectively discriminate between patients who had a good outcome and a bad outcome. But it gets very complicated, and you don't have the ability to really subdivide within these categories. And we were oversubscribed with patients in those categories. And that's a permanent feature of critical care service provision in Africa. And if you look at the scoring systems that try and help you define how you're doing in terms of your outcomes and your standardized mortality rates, you've got first day scoring systems and you've got repetitive scoring systems. Because do remember that it's a dynamic field in ICU, and it changes over time. If you think when you start to resuscitate someone who responds well to your antibiotic is very definitely a different kettle of fish to someone who does not respond over a period of time. And teasing those out with single time point scoring systems is actually very difficult to do. So ICU scoring systems actually need to use a repetitive scoring system. The ACOS study that Prof. Bickard published in the Lancet, of which we helped contribute patients, showed that African mortality across a multitude of ICUs was 48%. But I think what's really important to highlight, and is not published in the data in terms of what is the true need in the African setting, was just the data from the screening log for this study. 3,027 patients were not admitted to the ICU. So half of the patients that were actually objectively referred to ICU, and then remember that the doctors making the referrals are probably self-censoring it because they may be making those judgment calls themselves. So the need for ICU support in Africa is really not measured well, and probably vastly underestimated. And then just to show you, in Africa, there's a problem even with oxygen supply, with people using cylinder oxygen. We've got liquid oxygen on site. As an industrial country, we're very privileged to have that kind of resource. But we were busing tankers down from Johannesburg on a daily basis to maintain our oxygen supplies. If you're trying to do that with cylinders or other methods of oxygen delivery, you are really going to be struggling during a pandemic. And even measuring that oxygen, not all patients and centers in Africa reporting to an ICU outcomes study had pulse oximetry available. So the discrepancy in the amount of equipment and its competency is really a big differential. And if you look at our 743 patients, with our staff stretched, with our ECMO specialist sisters who are like gold dust in terms of trying to make patients have a good outcome, and looking after multiple ECMO patients, we are multiple ventilated ICU patients and proning them on a daily basis. We only managed to put 7 patients through our entire cohort onto ECMO, and we had equivalent survival to what you would expect in other centers in terms of those ECMO survivals, with our 3 survivors and 2-week ECMO runs. So what do you do in terms of critical care resources in Africa? I think you do have to, the ACOS paper was responded to by this group who we've actually ended up collaborating with going forward. And they used that paper to highlight the need for existing infrastructure in Africa to actually measure these things accurately. This group is using registry data, piloted in Africa, piloted in Asia for a number of years, and are trying to expand it into sites in Africa to actually try and measure this and use it for quality improvement. And we had to reply to say, look, that the ACOS paper was an unfunded network that quickly pivoted and did exceptional work. But it takes resources to invest in it, and that's what we need to really divert, because we need to be recording this data on a daily basis. And this is just to show you the SAMRC data on the excess deaths, because this is what happened during the waves, and what's reported as COVID deaths and the number of extra people who die. And I think we can see we've got a huge gap in the data capture that we're doing. And even if you look at the NICD data in this country, Northwest was apparently the best province to be admitted to ICU. So you can put that one in the bank. And if you look at the data recorded in this study that commented on racial disparities in access to ICU, it only records 52% of patients as being from the public sector and 47% from the private sector. And in South Africa, we know the maximum number of people accessing medical aid is probably maximally around 25% across the whole country. So there's an obvious discrepancy in how this data is being recorded, or potentially it's even access to before the hospital center. But I do worry that there are problems in how we're actually recording this data. And if you don't record globally and have a true reflection, then you're going to have real big gaps in your data. So as I've mentioned, we've partnered with this network to try and set up an infrastructure. And there's a new proposal to the EU who funded REMAP-CAP to actually try and do remap light, which means we keep the infrastructure to be recording our pneumonia admissions and ICU as a sentinel marker, as a resource that can then be pivoted during future pandemics and scaled up. And in the meantime, what do you do with that data? Well, you use it for all these process indicators in ICU that are really linked to ensuring good outcomes. We've had partnerships, and one of the other partnerships that came through from COVID-19 was this consortium out of Brisbane, Australia. And they helped us try to put together a research grant that ultimately didn't go through with Wellcome, but it was actually just purely looking at scaling up the amount of data. And this group and the patients we contributed to this international study, there's about 3,000 data points per patient that gets recorded over the course of a 9-day ICU stay on average. And they processed these flow diagrams of patients, the Sankey diagram, to try and see what resources were being used and what the impact was on the outcome, and number crunch the data very, very effectively with IBM, and now it's pivoted to Microsoft in terms of you could put in variables and then start to predict your outcomes, and then give the managers and the surgical services who want to know, are my staff being used the most effectively way? Because we're always disadvantaging and reallocating parts of the pie. And this plugged in patient variables, and there's a real focus on people to record patient variables. And if you look at it, here you've got patients under 70 with a SOFA score under 5 as per our triage criteria and what we would expect those outcomes to be based on an international study. But if you put in certain variables like HIV or BMI, you suddenly realize how small the numbers go. 27 patients with a BMI less than 18 and 43 patients with HIV/AIDS were in this registry. So you really can't make the prediction unless we start to record the data well in ICU. So how do you end up with the number crunching? You need clever doctors like Professor Bickard to do that. But even then, if you look at static markers like platelets or BMI, you end up with forest plots. And you also need to interpret the data, because I don't know how many of you think that male patients in ICU do worse or better. It's a common misperception, but you need to actually interpret this data in terms of there's already a male predilection in European ICUs in terms of 70% of admissions are male and 30% are female. So there's huge gender disparities in access to ICU, because I do say that human mortality is still 100% across both genders. So it's important to interpret, and what you hear from COVID in terms of male sex having a worse outcome, you need to really interpret that context on the basis of what pre-existing biases may exist. And it gets very difficult to tease out for us, did ventilation on admission, what degree of impact that have on the mortality, just by the way we structured our response, and were our admissions appropriate. And you use surrogate markers in ICU like age, but it's really important to say that age is just a number, and it's actually much more to do with the frailty. So there's even more levels to the data that you need to record, because we make assumptions on the easy numbers that we can stack up against each other. But medicine is definitely much more nuanced, and when you get to the critically ill, it becomes very, very nuanced. But we are recording the data much better. I find this very powerful data in terms of what our oxygen consumption rate is, and that's become a marker around the world for seeing how we're coping with the COVID-19 pandemic and what is the true strain on the healthcare system, because you suddenly just start to use a whole lot more oxygen. That's the green line there. So hopefully we can flesh out the data in critical care services in Africa. It's a complex field, but it needs good management, good clinicians, and a constant ability to reflect on what we're trying to do in order to use the money wisely. Thank you very much. Any questions?
Thank you so much. Thank you so much for a brilliant presentation. I'd like to open it up. Does anyone have questions? I mean, what's really nice about this group is there's, a lot of African countries represented just here, even though there aren't too many of us, but it would be great to get some insights. Dennis?
Hi there. Great talk. I was just curious, what you think the biggest need is in terms of critical care in your country? And is it a matter of having more beds or training, or obviously some combination of those things? But just curious, because it seemed like you were able to mobilize a lot of ICU beds for COVID, and then now, having to go back to making a lot of hard choices. What are the barriers to having more kind of ICU capacity?
Yes, so I think it is budget, and I think that healthcare is motivating for budget among multiple competing priorities, and your national government is setting a benchmark, and they're deciding how much goes to the military and how much goes to other social spending and other issues. And it is a difficult decision to get made. I think we in critical care need to be a little bit more visible in terms of what we're motivating for. I do think that critical care and theatre services sit at the top of a pyramid. We're very focused on primary healthcare. But actually using ICU as a sentinel marker of where strain can appear in the system. And I work as a transplant surgeon, and that was the first thing that disappeared during the COVID-19 pandemic. It just up and it went. It's a very cost, intensive, resource intensive field, and it got repurposed very quickly. Where do we need critical care? I think it needs a broad approach. We need to train more specialists in the field. And we need to capacitate our nursing staff, because if we looked at our hospital response and what was the ultimate rate limiting step within our hospital, it was ICU trained nursing staff. And that was even repurposing other nurses and trying to train them up on the fly. I would say nursing is our rate limiting step. Everyone thinks it's ventilators. We had so many hype about number of ventilators. We couldn't commission more spaces because we don't have enough plug points to deliver the infusion pump with the medication to keep the patient still on the ventilator. It's that was actually the rate limiting step in terms of commissioning spaces, physical spaces. I hope that it doesn't really answer your question. Like, is there one quick answer where we can start? I think it needs to be part of an overall strategy. And ICU struggled because we're dependent on our workflow in our setting, being registrars rotated from other disciplines. And that's the basis of our fundamental sleep-in workforce here. So we're always dependent. So we've positioned ourselves as a training center so that the registrars want to come here for the level of training that they get. And then they're getting something out of the deal for, sleeping in the hospital 1 night in 4 or 1 night in 5. But that requires everyone to buy in. If you want to say, I don't want to do that, then suddenly the system starts to creak.
Totally. I think I'm just curious if you've seen any shift in momentum, given that with COVID, it seems like, critical care came to the forefront and probably occupied a higher place in people's minds. So if not now, then this would seem like a really good opportunity, but I understand it's very, very difficult and to work this into policy shifts.
Yeah, I mean, I think that's a really good comment, because, how is it looking now? Because, a few months ago, that was the opportunity. Everyone now starting to recognize the importance, and now, are we using that momentum to kind of highlight the importance of paying attention and maintaining, what's the feeling from both of you?
For me, and I think I said it at the start of my talk, the most important thing for me is the dynamic nature. I think you can't treat healthcare as a static entity. And as long as you're continually reacting and trying to improve, then I'm happy to stay in a state sector system, as long as you really do think that it's trying to help and evolve as you go forward. And I think that's really important to give the clinicians that kind of feeling. So that's the only thing that it's not like a single resource. I don't want to hold on to 2 extra ECMO machines or 5 extra ventilators. I actually want to hold on to the relationships that we've got with management that says, I have a 20-year-old who's blocking a theater in this hospital and I need to move them into an ICU. I can give them a 50% chance of survival, age 18, this number of organ failures, you need to help me. And keeping those relationships is what we need to maintain for me. And whether that can then just become a permanent state of affairs and slowly build the service, that would be a hope. But ultimately, the managers will hit that money budget limit again and then tell us no. Shri, I don't know if you want to comment.
Yes, no, I think it's very important. I think what David refers to in economics is this concept of a margin. You get a certain value for everything you add on. And unfortunately, with all healthcare services, but especially in ICU, there's a limit to what can be provided. And it is messy at the margin. It's a call in the middle of the night, the Hail Mary pass, where you've got this bleeding patient who is 17 years old and needs a bed and there isn't anything available. Or you've got two 34-year-old pregnant ladies at age 35 weeks, both with COVID, both needing intubation, both needing to be delivered, and you've maxed out all your beds. So that's taken to the extremes, but it will always happen. And at that point, you will always need to have a functional relationship between non-clinical budget holders and the clinicians on the floor. So I think that's very important. I think, moving forward, there needs to be this discussion around distribution of beds. Yes, we'd like more and we'd like to build on our service marginally, but we'd really like distributed beds, if those are ICU beds or if they're high care beds out at district hospital services. And that argument goes together with the global surgery drive towards capacitating our district hospitals, because it's an important resource, and ICU and high care are important support structures to other services. And I think if we build that kind of argument, we detract from the view that some clinicians have of ICU being an ivory tower that says you will have so many nurses and you will have this environment. And if you can't guarantee that for a patient, we're just not going to accept your patient. And so there's a lot of possibilities for conflict between clinicians around the way we use our resources, and then obviously between clinicians and managers. So I think we've built good relationships with COVID. It's important not to retreat into our various silos as we move away from the immediate crisis, because there's always ups and downs as we go through the months. And we need to start really talking to provincial district level authorities about how we distribute our ICU and high care services better. Thanks.
Thank you very much. And just probably a last one from me. I mean, this concept of delayed access, and I like how you showed that 6,000 people actually needed 8,000. The beds, but 3,000 got them, and often the adverse outcomes are related to getting there too late in the first place, and so and then the other part for me was also just trying to marry the two talks together, because on one hand it's looking at it through the lens of numbers and rates, etc., and the other one is more about these are people and these are outcomes, and this is what and it's I suppose, and I think that's what makes global surgery unique, that we're taking in both sides and trying to see how to use both sides. But I mean, incredible insights from both of you, and I think we've all benefited from this. But Dave, you want to say something?
No, I was just going to say it's very difficult in ICU because you think of it as an ivory tower with resources. And I think back to where we were pushed further beyond where we'd been functioning during the COVID wave. And then all it took was a pan-resistant Acinetobacter outbreak of IPC breaking down, and the mortality rate goes up by 5%. And it really, it's a very fine line that you're actually walking. But I like your point now that global surgery is trying to marry the two, because I think ICU really does put an individual face. Like we can talk vaccination, we can talk broad access to things, but if you want the physical story to highlight your case and the human element, then it boils down to the individuals in the end, and pulling those ones through with ICU really does help the healthcare system.
Yeah. But thank you so much to you both for the incredible work that you do and continue to do. And thank you for making the time to share with us today. And looking forward in the future to having more talks like this with you. One more hand. Sorry, just one last. We've got 2 minutes left. So, Dr. Eke.
Hello, everyone. Good afternoon. Hope you can hear me.
Mm-hmm.
Okay, I'm Dr. Eke. I'm a general surgeon currently working in a provincial hospital in Polokwane. So thank you for your thoughts about the structure of the healthcare system and how critical care plays a role in terms of the management of the hospitals and healthcare systems and the clinicians. And my question is from the recent pandemic, which we are just recovering from. Is there a nationwide structure in place? Because there's a bit of inequity of critical care in the whole of South Africa. As you said, most critical care services are in the private hospitals. And then also the survival rate for Northwest was way better than other provinces. And I know, like you've said, that there are very few trained critical care nurses as well as specialists. So is there like a critical care society that is trying to bridge the gap between the healthcare delivery system of the private and public hospitals and in different provinces? What I mean is there any structured training for nurses, organizing the CMEs for them? And because most hospitals generally run an ICU, but it's not an ICU. They just have a ward where their patients were intubated. Some of these patients get admitted by the nurses. There's no specialist or even intensivist who sees the patient. So, because I don't know where we are now, are we going to improve from this pandemic, or we just going to be one of those stories in the past where our critical care system had the opportunity to be boosted and we just neglected it and we moved on after that?
Yeah, I hear your points. There's a very strong professional society, the Critical Care Society of Southern Africa, and their conference is coming up in October in Johannesburg. It's about 1,000 people, and it comes across allied health in terms of it's very multidisciplinary. So I think we're in a good place in terms of where that society sits. It is driving that the college exam is quite difficult to pass as a subspecialist, and I think that's partly because critical care is so broad, and people do end up training in critical care in an area where there's limited scope in terms of what the range of patients you may see. So if you're only exposed to obstetric patients, then that's your bread and butter, and you can fill your entire life with that. You may not be able to answer the question about a traumatic brain injury patient. So it's difficult to train. There's now a national training platform for the subspecialists with a program going to try and help redress that, and that'll also help how we're teaching it. Nursing is its own issue in South Africa, and I think it's a capacitation numbers issue that I am worried is not fundamentally structurally being addressed centrally. We unfortunately did not put in very good, and that's why I highlighted the NICD paper in terms of I don't think we're adequately recording the number of beds and what they're being used for. Because what a private bed in ICU, that just changes the billing code for the clinician there. That doesn't necessarily change what's happening in the bed. So I do think that you need those registry type data to be able to call yourself an ICU. Maybe it's not actually the bed or the nurse ratio. It's actually the severity of the illness of the patient inside and what outcome are you delivering. And then the other part becomes a moot point. But I don't think we're there in terms of measuring it that way. But if I had an ideal that I wanted to work towards as to how we would be measuring what an ICU is, that would be the standard I would want to hold them accountable to, and then allow them to build that on that level. Yeah, so that's where we are. So I'm worried that we don't have a national strategy, and it's just going to grow up with champions in various areas and hopefully snowballs out from there.
Thank you so much. Well, interesting point that you raised there. We all know how high the failure rate is. And I'm glad something is being done about that. But yeah, thank you very much. We've run out of time. So thank you so much for joining us, and have a good afternoon.
Bye. Thanks, Lynn.